And we should be live.
Good afternoon, everyone. I'm Senator Jeb Bradley from Senate District 3. Today, we will be holding a meeting of the Senate Health and Human Services Committee. Before we get started, I'll read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As chair of the Senate Health and Human Services Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order number 12 pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that, 1, we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. 2, we have provided public notice of the necessary information for accessing the meeting in the Senate calendar. 3, we're providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate, all one word, remotesenate @leg.state.nh.us, or you may call 603-271-6931. In the event the public is unable to access this meeting, it will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done by a roll call vote. Finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. So I'm going to start by calling the roll with Senator Whitley.
Senator Whitley is here in my house in Hopkinton, and my family is in the house, but I'm alone in this room.
Senator Sherman.
Senator Tom Sherman, I am alone in my home in Frye.
Senator Gray.
Senator Gray, I'm in my home in Rochester, and I'm alone in this room.
Senator Avard.
Senator Avard, I'm here in my office in Nashua, New Hampshire. We have a couple of people in the house and a dog and a cat.
And I'm Jeb Bradley, and I am in Wolfboro in my home office and alone. Okay, so the first order of business is to open the hearing on Senate Bill 34. And I would like to recognize the prime sponsor, Senator D'Alessandro from District 20.
Okay. Let me. Senator D'Alessandro, you should be able to unmute now.
I'm unmuted, Trace.
Okay.
And I see your lovely face.
Senator.
Makes me warm.
Oh, thanks.
Thank you. Thank you so much. Thank you, Senator Bradley. For the record, I'm Senator Lou D'Alessandro. I represent District 20, Manchester wards 3, 4, 10, 11 in the town of Goffstown. and I come before you as the prime sponsor of Senate Bill 34 FN. This piece of legislation was heard before the Senate in the last session and passed. It went on to the House, but was somehow displaced, misplaced, or dropped off. But so we're bringing it back. The bill was initiated by the Department of Safety and by the former police chief in the city of Manchester, David Mara. The bill does basically three things. The bill inserts a new definition of controlled drug analog. It inserts a prohibition on the sale or possession of synthetic urine and urine additives, and it repeals obsolete statutes governing the sale of synthetic drugs. There are people from safety who are going to testify and can get into the details, but the purpose of the bill was to give those in our police officers what they need in terms of ascertaining if someone is on drugs and the drugs can't be masked. And indeed, that's the purpose of the legislation. As I said, someone from safety, from the lab, will be here to give you a more delicate interpretation, and we'll go through the bath salts, the drug analogs, the synthetic urine, and let you know what role they play in in analyzing if a person is on a controlled drug. I appreciate the great work that's done by the committee, Senator Bradley, and really kudos to the Senate staff for the wonderful way they handle these hearings. I've been on a lot of these, and indeed, it's really remarkable that we're pulling this off with such efficiency and effectiveness. So must be a tribute to Senator Bradley, because he's the Wizard of Oz. He does great things all the time, and that's why we think so much of him.
Yeah, well, flattery will get you. Flattery will probably get you somewhere, but I typically call all the staff who are doing these meetings are geniuses, because I agree with you, Senator D. They pull it off remarkably well. Are there questions of Senator D'Alessandro? Seeing no questions, we'll release Senator D'Alessandro. And for today's proceedings, I'm going to have Trish just go through the order of the speakers.
Okay. Next, Senator Bradley, we have Melissa Staples from the Department of Safety.
Good afternoon. My name is Melissa Staples. I'm the director of the New Hampshire State Police Forensic Laboratory, and I wanted to speak to give you a little bit of background on the current legislation regarding the drug analogs and the limitations that it presents, which is the purpose of this proposal to amend the legislation. Drug analogs such as bath salts are really becoming prevalent again in the state. If you think back around 2014, there was such a public emergency being posed by drug analogs such as spice that then Governor Maggie Hassan declared a state of emergency in the state due to instances involving overdoses on these bath salts. And for a while, the emergency legislation that was put in place really quelled the instances of these drugs in the state. But there has been an uprise again, particularly in the western part of the state, of these drug analogs. It's causing medical emergencies, increases in crime. But the problem is the current law really does not support prosecution for these drugs. And I want to explain a little bit about why that is and how this proposed legislation would correct that issue. The current verbiage defining what a controlled drug analog is says it's a substance that has a chemical structure substantially similar to that of a controlled drug, and that was specifically designed to produce an effect substantially similar to that of a controlled drug. There are problems with each of the two components of this definition. First of all, substantially similar is not defined. What is substantially similar to a controlled drug? There really is no guidance for a prosecutor to point to move forward with the prosecution of a drug analog to determine it was substantially similar. The second part of that definition says that the analog was specifically designed to produce an effect similar to that of a controlled drug. This is essentially requiring the prosecution to prove what the person who manufactured the drug was thinking. What was their intent when they produced this drug? Did they intend for it to have an effect similar to a controlled drug? That's something that's almost impossible to prove. Now, not being there in person, I can't tell if there's maybe someone from the AG's office or a county attorney's office that may be able to fill you in on their efforts in this regard. But the current definition makes it very difficult to prove those components in court. This new bill really solves both of these problems. On page 2, line 10, you'll see that there's a new definition of what a substantially similar structure is. And that provides guidance for attorneys in court attempts for prosecution. Also, the portion that said specifically designed to produce an effect is now changed to that the intent of the manufacturer is to, page 1, line 23 shows the new verbiage, which takes away the intent of the manufacturer and replaces it with the ability to produce laboratory studies which show the analog essentially has the same effect as the original drug. So this is a more scientific definition. Communications with the DEA show that they are pretty quick to produce those studies, which may indicate that the analog interacts with the same drug receptors as a known controlled drug. And that really supports the effect scientifically rather than what the manufacturer's intended effect was. So the definition of controlled drug analog through this bill is greatly improved so that prosecutions can be more successful. The second portion of this bill, when we get to page 2 and line 18, repeals Chapter 359.0. Currently, that portion of legislation was a stopgap measure to prohibit the sale of spice and bath salts in retail establishments. This legislation was put in place at a time when people could purchase these drugs at the corner market, and it made it a violation to sell these types of analogs. And it was successful in getting the products off the shelves, but then they just went underground to the black market, and the analog law could not be enforced effectively. With the new definition of analog, this section of 359.0 is no longer necessary, as sales in retail establishments could be prosecuted under the new definition as a felony offense. The proposed Chapter 359.0 is regarding synthetic urines. Synthetic urine samples really have no legitimate purpose. They're designed specifically to provide blank urine samples for individuals who must take drug tests. Perhaps they're taking a drug test as a condition of employment. Maybe they have a CDL and they're driving 18-wheelers. Maybe they're driving heavy machinery and need to be drug tested. Maybe they are under probation or parole and have state supervision. Maybe they're in a rehab program. But these products are sold under names such as Quick Fix, Ultra Pure, Magnum Detox, and they have no legitimate use other than to essentially give a clean drug test. An individual who utilizes these synthetic urines could be putting others at risk or prevent themselves from receiving services such as rehab, which could be beneficial to them. Individuals who maybe have CDL licenses and are using these products could be putting other people on the road at risk if they're driving under the influence of particular drugs. And so it's important to include these synthetic urines as well as part of this bill. Hopefully I've clarified the importance of this bill, and I'm happy to take any questions that you may have.
Thank you very much, Ms. Staples. Are there questions of Ms. Staples? Just one thing then, Ms. Staples, and thank you very much for your testimony. Did you have that testimony in writing? And if so, can you make sure that we get it? If it's not in writing, it's fine because it's recorded, but just be easier.
I do have not quite I have my bullet points and things that I'd be happy to provide if you would like. It has those key points there. Yes.
Great. Thank you so much.
Thank you.
Okay, Senator Bradley, we now we have Robert Oaksley from the Department of Corrections.
Go ahead, Mr. Oxley.
Oxen.
Good afternoon, Chairman and honorable members of the Senate Health and Human Services Committee. My name is Robert Oxley, and I'm the Director of Field Services for the Department of Corrections. And we are in support of Senate Bill 34 for the following reasons. Senate Bill 34 seeks to correct the problems with how New Hampshire currently defines controlled drug analog within the law. As the law stands today, New Hampshire's current analog definition is unusable as written. The requirement that the potential analog drug was specifically designed to produce an effect substantially similar to a controlled drug is also impossible to prove. Not only do we have no idea who designed many of these novel synthetic drugs, but most of them are from China. We certainly cannot presume what their intention was. SB 34 appropriately changes the definition, focusing on the chemistry rather than the drug dealer's intent, making this adjustment that a controlled drug analog has a chemical structure substantially similar to the chemical structure of a controlled substance and has a stimulant, depressant, or hallucinogenic effect on the central nervous system that is substantially similar to or greater than the stimulant, depressant, or hallucinogenic effect on the central nervous system of a controlled substance. The adverse effects of New Hampshire's definition of a controlled drug analog, when specifically dealing with bath salts approximately 5 years ago, first affected the Department of Corrections Claremont District Office in Sullivan County. These chemicals have been an ever-increasing problem for the Department of Corrections, specifically Division of Field Services. Probation and parole officers within Sullivan County were aware that some of their probationers and parolees were showing all the signs of drug-induced high, including but not limited to dreary eyes, physical apathy, and time lapses in their judgment. Current urine testing utilized by the Department of Corrections and the New Hampshire State Laboratory confirmation process does not detect certain controlled drug analogs, to include bath salts. The probation and parole officers have relied on probationers and parolees' self-admissions and observations of controlled drug analog paraphernalia in their possessions or property. Bath salts are just one example of a substance structured in order to mimic a controlled substance and the effect of the high, but with a limited ability for the probation and parole officer to effectively screen for use of the controlled drug analog. This makes the synthetic drug type a popular choice for drug users, and there is limited exposure for detection by probation and parole officers. U.S. Customs have made the Claremont District Office of Probation and Parole aware of a recent sizable seizure of bath salts in the last 3 to 4 months of about 7 to 8 packages of bath salts addressed to Claremont and nearby Newport in Sullivan County were intercepted and seized by U.S. Customs and eventually turned over to the New Hampshire Drug Task Force. These packages have an estimated street value of at least $100,000. Although these issues started in Sullivan County, it has expanded out to Hillsborough County and Belknap County that we are aware of, and possibly others. As drug dealers continue to get more sophisticated in the area of controlled drug analogs, we expect to see more in the future throughout the state of New Hampshire. The proposed adjustments in Senate Bill 34 allow our probation and parole officers to focus on combating these sophisticated synthetic drug types, such as bath salts, with a prosecutorial tool and not an obstacle by not requiring the unrealistic testimony from a drug dealer or chemist that they designed their drug to mimic a high. This effective tool to combat such a devastatingly harmful drug such as bath salts will improve the lives and opportunities for those in the communities mostly impacted by these synthetic type drugs. This will also improve rehabilitative opportunities for the probation parole population, as this law will allow effective enforcement against the synthetic drugs and will make these type of drugs less available. The department appreciates the support of Senator D'Alessandro and others for bringing this bill forward to align our state definition to the federal definition, while also giving those working in New Hampshire communities the tools we need to stop the spread of these drugs and continue to focus on public safety. Thank you again for this opportunity, and I'm available for questions.
Are there committee questions of Mr. Oxley? Seeing none, I have one. Is there anything in this bill that would impact somebody who has a prescription or whatever it should be correctly referred to for medical marijuana.
Senator, not that I'm aware of. I don't have the chemistry background, but I can certainly get you an answer to that question.
Okay, thank you. Seeing no further questions, thank you very much.
Thank you.
We do not have any more speakers signed up. If there's anybody watching that would like to speak, if you could raise your hand on your screen. If you are on a phone, it is *9. Okay, Senator Bradley, I have 2 hands raised. This is Aiden Moore. Mr. Moore, you can go ahead and unmute. There you go.
Thank you very much, Mr. Chairman and committee members. The Liquor Commission, if you notice, Senate Bill 34 has language in the first page that speaks to a reorganization of essentially the provisions in RSA 17957, Roman 1. The bill takes essentially the same language that exists in Section 1 currently and provides it with I guess, a better detailed breakdown so that it's easier to read. The substance of what occurs in that section of the bill really provides no change to what exists in current law. And those provisions were used, as you heard from Ms. Staples from Safety, initially when these products were out on the market. They were in businesses that were licensed to sell alcohol. And this provision under 17957 was a provision used to get the products out of the stores and to provide penalties for those businesses that did not comply. So I just wanted to bring that to your attention and to see if there were any questions about the first part of the bill.
Are there any questions of Mr. Moore? Seeing none. Thank you very much.
Thank you.
Okay, I have one more hand up, Senator Bradley, and the name, I don't know if it's Mr. Light or Ms. Light.
Yes, Mr. Light, thank you. John, my name is John Light. I'm here on behalf of myself from Manchester, New Hampshire, and thank you all for the time and opportunity to contribute here today. I'm here to oppose SB 34 for 3 reasons. The first reason I oppose this bill is based on the separation of concerns principle. The bill intends to achieve 2 quite different and unrelated goals at the same time. First being to redefine the definition of controlled drug analog and amend sections of the law related to drug analogs. And the second being to ban synthetic urine and urine additives. So, legislators and the public are therefore forced into the potentially uncomfortable position of either accepting both or neither of these items, even though they may support one but oppose the other. And so, on this basis, I recommend at least splitting these concerns into 2 separate bills so that the merit of each of these goals can be considered and voted on separately. The second reason I oppose this bill is for the paternalistic government control that the bill places upon New Hampshire residents and entrepreneurs by banning the manufacture, possession, and sale of physically harmless substances, namely synthetic urines. I completely sympathize with what I assume is the motivation for this ban, which is to prevent people from using such products to defraud either the state or employers by faking a drug test. However, in these instances, it is already possible to deter such fraud by imposing penalties for the fraud itself. For example, the state can impose a penalty on probation and parole offenders who use synthetic urines or additives to fraudulently pass a drug test. And employers can similarly impose penalties on employees who use synthetic urine or additives to do the same. The problem is not the substance, which may have non-fraudulent uses, for example, in pranks or theatrics. But the problem is the fraudulent use itself. And as I have noted, such fraudulent use can already be dealt with using penalties set by the state and employers in the agreements that they have with any counterparties whom they wish to deter from fraudulently using such substances. The third and final reason that I oppose the bill is that the long history of drug prohibition has shown that prohibition doesn't work. Criminalization has not slowed or stopped drug abuse, and in fact, by virtually any measure, drug abuse and the black market for drugs has only gotten worse since the prohibition of drugs first really took hold in this country in the 20th century. We should be repealing these ineffective laws, not doubling down on them by making them more stringent. For all of these reasons, I ask that you reject this bill in its entirety. Thank you for your time.
Are there questions of Mr. Light? Seeing none, thank you very much for your testimony.
Thank you.
Okay. And I do not see any other hands, Senator Bradley, so.
Okay, so I will close the hearing on Senate Bill 34 and the time being 1:26. Open the hearing on Senate Bill 45 and recognize the prime sponsor of Senate Bill 45, Senator Guido.
Thank you.
Okay. It's not working.
Thank you, Mr. Chairman, members of the committee. Can you hear me now?
Yes.
Thank you. My name, for the record, Bob Guida, State Senator from District 2 and prime sponsor of Senate Bill 45. At this time, I would like to introduce Amendment 0028S, which I believe the committee should have in its possession as a replacement for the bill. This is some history that's required for this. I have taken on, as a sort of a personal oversight matter, the privacy issues relative to the PDMP, Prescription Drug Monitoring Program. The protecting the individual data and the privacy of patients who are in fact recorded in that database was a paramount priority of the legislature and remains so to this day. In the course of its creation and its subsequent journey, the PDMP has started out as a subset of the Board of Pharmacy, which was then within the purview of OPLC, Office of Professional Licensure and Certification. That became problematic, and the PDMP was then relegated to the OPLC Executive Director for Administration and Oversight. Though responsibly managed, nonetheless, it doesn't belong with OPLC. Professional licensure and certification has nothing whatsoever to do with the data requirements and the use of the PDMP. That's background. The governor has proposed moving the PDMP from OPLC into the Department of Health and Human Services. Over the past 3 years, I have chaired a number of stakeholder working groups relevant to and developed legislation for expanding the use of the data within the PDMP very carefully and under very controlled circumstances. We have 2 bills this year, one of which is yet to be assigned a number, but it's LSR 210833. And then we have this LSR 210833 will take the PDMP data and make it accessible through the electronic health record system of hospitals and doctors and providers and dispensers. And that will protect federally sourced funding for HHS in that realm and for our hospitals and our doctors' offices. Absent doing that, we would lose that funding. So that's one bill. This bill addresses specifically the use of data within the PDMP. Originally, the bill had incorporated provisions to enable HHS with the permission of OPLC and under the advice of the PDMP Advisory Council to utilize this data in a de-identified capacity. I am concerned, and I'm concerned because, as will be explained later in testimony, the record of the HHS with respect to guarding the privacy of that data is less than stellar. And so for those reasons, myself, Senator Rosenwald, and Senator Sherman have sponsored this amendment that, understanding that the governor wants to move this to HHS, we're taking this one step at a time, one iteration at a time, and being very careful and deliberate in our protection of the privacy of data of those individuals whose names and data are contained in the database. For that reason, I offer this amendment with the co-sponsorship of both Senator Rosenwald and Senator Sherman, who have both been partners in developing our legislation in its iterations and increments to gradually liberalize but carefully control this data. We support moving the PDMP to HHS. At this time, we think it would be potentially hazardous to the privacy of those individuals contained therein to go ahead and enable HHS to start using this data. I ask the committee's support for this bill. It's necessary. As I think you will hear, that the executive director of OPLC is also in accordance with this, but I'll allow Executive Director Courtney to testify on that behalf, on her own behalf in that regard. I'll be happy to take any questions.
Thank you very much, Senator Gaida. Are there questions of Senator Gaida? Senator Gaida, just one then from me. So if I'm understanding this correctly, this amendment, which would replace the entire bill, does not accomplish the move to the Department of Health and Human Services. It is merely privacy protection. Is that correct?
That's correct. Understanding that the move to HHS is going to be coming forth, I believe, with the governor's budget.
Okay.
And while we don't oppose that, what we do think is one step at a time. Let's get it over there, get it situated, get it manned and personnel assigned and so forth. And at that point, we will address the issue of how and if HHS can in fact access and utilize that data.
Okay. Any further questions of Senator Gaida? Okay, seeing none. Thank you.
Thank you, Mr. Chairman, members of the committee.
Okay, next we have Patricia Tilley. And I don't see her.
I know she had to leave at 1:30, but John Williams from the department has raised his hand. I'm sure he'd be able to speak more to it.
He's gonna.
Why don't we recognize then Senator Rosenwald, who I believe wanted to speak first. Maybe Ms. Tilley can rejoin us in a few minutes.
Okay, Senator Rosenwald, you should be able to unmute now.
Thank you very much. Thank you, Mr. Chairman and members of the committee. For the record, I'm Senator Cindy Rosenwald, and I have the honor to represent 6 of the 9 wards in Nashua. And I'd like to speak in favor of Amendment 0028S. And I'd like to thank Senator Gaida for working with me on it, and Senator Sherman as well. Currently, DHHS has access, because it's the payer under HIPAA, to the confidential health information of people who are on Medicaid. But that's only 15% of our population. Senate Bill 45, as introduced, would give HHS access to the confidential health information in the prescription drug monitoring program of the other 85% of New Hampshire residents. And we're not only talking about the opioid history of all Granite Staters. This would also include children who take drugs for ADD or ADHD, men with low testosterone levels. Even people who have trouble sleeping and take a drug like Ambien would have this history accessible to the department. And I think this is overly intrusive. It would be different if HHS were paying for the prescription drugs of the entire population or in charge of treatment, but they're not. And I would also be comfortable if the department was asking for de-identified prescription drug information, but not the identified confidential health data of the entire population, which is what the department's asking for. This amendment before you is what Senator Gaida and I and Senator Sherman were going to propose last March when the bill got tabled out of finance during the stay-at-home period. And I hope the committee will look favorably upon it and agree that state government should not be given the confidential health information of identifiable individuals for whom they are neither the payer nor the provider. Thank you, Mr. Chairman.
Are there questions of Senator Rosenwald? Seeing none.
Thank you.
Okay, do we want to go to John now, or John, do you want to wait until maybe Ms. Tilley can return?
Senator Bradley, for the record, John Williams, Legislative Director for Health and Human Services, and thank you for the opportunity to speak on Senate Bill 45. Ms. Tilley is doing a presentation between the Joint Senate and House Ways and Means Committee, and I expect that they'll have her there till 2 p.m. today. So we are prepared to go forward, and Ms. Tilley, through her normal due diligence, has provided some talking points and notes that I will provide to Mr. Roberge after this hearing. But I think it will be very helpful to demonstrate the need for the Department of Public, rather the New Hampshire Department of Health and Human Services to having access to this information. I also have on this hearing Dr. Jonathan Ballard, MD, our Chief Medical Officer, and hopefully I have Attorney Melissa St. Cyr, who's our Chief Legal Officer, who can respond somewhat to the privacy concerns that were raised. So Senator Bradley, if I could proceed at this point.
Okay, go ahead.
So to begin, I just wanted to thank Senator Gaida for his leadership. We've been working with Senator Gaida now for over a year and a half, and he did put together a task force. And you probably remember last year when we testified on the last year's iteration, which was Senate Bill 676, that this committee met the bill very favorably and did pass the bill out of the committee. I do know, and I also want to thank Senator Rosenwald. She's also a very incredibly thoughtful person, and we have worked with her in the past to make sure that legislation is drafted in a way to protect the privacy concerns, but also balanced with the public health interests that we're trying to achieve. And with that, I just wanted to thank both Senator Gaida and Rosenwald, and also including Senator Sherman, because I know he's been working with Senator Rosenwald on this issue as well. And we look forward to the opportunity to continue to work with those senators and also members of this committee in the Senate to see what we can do to accomplish the goals of the department, as well as protecting the privacy interests that have been identified in the testimony by Senator Gaida and Rosenwald. So to start off with, it is mentioned that the department, working along with the governor's office, is looking for the transfer of from the Office of Professional Licensure and Certification to our agency. But as we know, the budget goes through, its process, the House phase, Senate phase, committee of conference, and it's never a given as to what can happen during the course of the budget activities. So this is why, with great appreciation to Senator Gaida, by bringing forward the bill that was brought last year, Senate Bill 650, or rather 676, which is now Senate Bill 45, as introduced, that it gives us a very viable option as a backup in the event that the larger picture of moving or transferring those functions to HHS do not happen. And so the bill as introduced is particularly helpful to the department. I just want to really point out that the work that Senator Gaida did included various state agencies, including the Office of Professional Licensure and Certification, the Department of Health and Human Services, Department of Safety. It included various legislators. I know Senator Sherman, you served on the task force along with Senator Gaida. And we really worked hard, and also with Dr. Strang, David Strang, who is a member of the Advisory Council for the PDMP. We worked very hard at crafting this language. And even with Neil Kirk's, Representative Kirk's participation, came up with language that was agreeable to all the parties. I do understand that one very important contributor was not part of that process, and that was Senator Rosenwald. And again, we look forward to the opportunity of working with her, but this language as introduced has been worked on more than once. And in fact, we reconvened again this fall to rework on the language, and essentially what you have as the bill is introduced has been vetted with a very direct interest in protecting privacy concerns and interests. So going to Patricia Tilley, Ms. Tilley, our Deputy Director for Public Health, the information she was going to help offer was to explain to you the need for the information for public health purposes. And if you see the bill as introduced, and she would have highlighted it, you'll see in the intent section of the bill as introduced in section 1, which has been removed as part of the replacement amendment, that the purpose and intent of the legislation is to improve health and well-being of New Hampshire citizens by authorizing meaningful access by the Department of Health and Human Services to data, including identifiable patient-level data or information from the Office of Professional Licensure and Certification, Controlled Drug Prescription Health and Safety Program for public health purposes, including but not limited to public health evaluation, coordination of healthcare, and for the delivery of critical services to address substance use disorder. Section 2 of SB 45 as introduced is essentially the Department of Health and Human Services section that allows for the receipt of that information. And as you'll see, as it's being very carefully crafted, it is designed specifically to ensure the protection of the information that the department would be receiving from the Office of Professional Licensure and Certification. And in Roman 2, under section 2 of the bill, you'll see there that around lines 14 or 15, I apologize because the pagination of the bill that I have in front of me is slightly off, but it provides in substance that this information received is not a public record, are otherwise subject to disclosure under RSA 91A, is not subject to discovery, subpoena, or other means of legal compulsion for release, and shall not be shared with an agency or institution except as provided in RSA 318B34 under the section. And you'll see in the reciprocating section with the Office of Professional Licensure and Certification, and I'll defer to Attorney Lindsay Courtney, who is the Executive Director for OPLC, who is, I believe, is on this as well, to go over their sections, which was very, very carefully crafted to ensure the protection of this information. But critical, and what we worked so hard on as a group, was the concept of working out reciprocal data sharing agreements that you'll see reflected in Roman paragraph 4A. And again, it sets forth, as mentioned in the intent statement of the bill, that it's used for public health evaluation, coordination of healthcare, and for delivery of critical services to address substance use disorder. It then goes on, carrying on at the bottom of page 1 into page 2, to identify the components of the data sharing agreement between the two agencies, to include the specific purpose of sharing data, a detailed description of the data sets that will be included, the criteria and procedures for the development of data sets, the criteria and procedures to ensure data security and destruction, and an appropriate time frame in which the data shall be used. It further says that under no circumstances shall the data or information received by the department under the section be copied or released by the department to any other person or entity unless the data information is aggregated or otherwise de-identified. So as much as we do appreciate the concerns for privacy, I think by the language that I just read to you, it also reflects that both agencies that are involved also equally feel very strongly about the protection of the privacy and the information that we'd be receiving. And I will at some point very soon defer either to Dr. Ballard if he's on the call, and or Melissa St. Cyr if they could just provide their thoughts, particularly Dr. Ballard, on the need for this information, because as Dr. Ballard has said in the past, this information will allow the department to save lives. And that's the bottom line and goal of what we're trying to do. And also to identify areas where we can promote good education, particularly around individuals who have co-occurring disorders, mental health issues, behavioral health rather, and other issues that we can now more focus our effort with information that we currently do not have access to. And I do appreciate all the good work that's been done by Senator Guida and Senator Sherman around this issue. And we look forward also to working with Senator Rosenwald, who I've had the pleasure of working with in the past and anytime I've ever worked with Senator Rosenwald, it always worked to improve the legislation. However, by removing sections 1 and 2 of the bills introduced, you've essentially taken away the entire underlying bill with the exception of a few other pieces, including the pieces that are remaining involve the electronic health record, which my understanding is being moved to a separate piece of legislation that Senator Rosenwald, I believe, is going to be sponsoring, or perhaps Senator Sherman, at the request of New Hampshire Hospital Association. So you're really left with very little at the end of the conversation with the bill by removing those key sections that allow our agency to share information with OPLC. And with that, I didn't know if Ms. Malilla or Mr. Roberge are able to bring up either Dr. Ballard and or Melissa St. Cyr. And I'll conclude my testimony at this point and open to questions, but it'd be good to hear from them, Senator Bradley, if you're okay.
That would be fine if Dr. Ballard or Melissa St. Cyr are on the line. I see Dr. Ballard is. Why don't we go to you, Doctor?
Good afternoon, Mr. Chair and committee members. Thank you for this opportunity. For the record, my name is Jonathan Ballard. I work as the Chief Medical Officer of the New Hampshire Department of Health and Human Services. I've been with the department for about 3 years, and I am a family physician. The purpose of this legislation originally, from my understanding, to create a prescription drug monitoring program is to save lives and to work as a tool for practitioners to use in their ability to safely prescribe and dispense these medications. The purpose of this legislation has worked on for multiple years now by our department and the other stakeholders is simply to save lives. We are very much in the middle of still a pandemic for opioid misuse and abuse. We're still having over 200 persons in New Hampshire die this past year from fatal drug overdoses. We have an urgent need to take additional steps, and this is a step forward in the ability for our Division of Public Health Services, as well as other members of the Department of Health and Human Services, to use this identifiable data to offer services through better understanding of the drivers that lead to the outcomes that in a fatal drug overdose. Without the identifiable data, our department is handicapped. Our department has the inability to make those determinations by understanding the trends that lead to this that can be obtained from the identifiable data in this data set. The state already, has this data. It is not new. It is not a new effort to obtain this data for state purposes, but it actually allows the entity, public health, that is responsible for saving lives and carrying out public health practices to use it. So with that, I think I'll, in my testimony, if Melissa St. Cyr is on the line, that can speak to the actual legal privacy issues. Also open to any questions.
Dr. Ballard, Senator Sherman has a question.
Hi, Dr. Ballard. Good to see you or hear you again. So I think we may be hearing from former Representative Kirk on the original intent of the PDMP. And I actually do understand why it was put in the Board of Pharmacy, because that really did reflect its original intent. But, this issue of how much access others should have, I think in my world, similar to yours, being a practicing physician, I worry somewhat about mission creep. We have fiercely defended the access to the PDMP in terms of how law enforcement has access, and really virtually anybody but pharmacists and practitioners. So I'm trying to understand exactly how the department would use individual identifiable information. Would you go to I know there's a commission that looks at actual deaths from overdose. Would you be querying the PDMP to look for a pattern of behavior in that deceased overdose victim? Would you be, back when we first heard this bill, I know John Williams was talking about doing some aggregated analysis to look by region and see where the department might direct their efforts. I think the reluctance that I have to opening the PDMP really stems from understanding its original intent, having been a part of a lot of the early work by the state on the opioid crisis, along with Senator Bradley and Senator Rosenwald, and then really understand, trying to make sure that any additional access to the PDMP has a clear and definable purpose. And I understand that we all want to save lives, but what is an example of exactly what the department would use this information for?
Senator Sherman, thank you for that question. I can give you a very specific example. There is a big question for us in New Hampshire in public health terms for solving the opioid epidemic in the trends that progress for our young persons to develop into the addiction. Does the abuse of, for example, ADHD medications that Senator Rosenwald mentioned at a teenage level, does that progress into an opioid addiction? Are there patterns that exist in New Hampshire, particular localities, in the progression that can have interventions through public health measures in releasing the data in a de-identified and aggregated matter once those trends are identified? It is impossible to do that analysis in a de-identified data set initially, but within the scope of this bill, we will be able to tell you those trends that will have immediate public health impact that the state, that the Governor's Commission on Alcohol and Other Drugs could devote funds to interdict and stop that progression. It would be just one example. We have many others as well.
Thank you.
Further questions of Dr. Ballard, Senator Whitley.
Thank you, Mr. Chair, and thank you for taking my question, Dr. Ballard. My question is similar to Dr. Sherman, Senator Sherman's, in that, I want to, go back to that and back into the need for the identifiable data. You mentioned, that the need, that what I'm hearing is that the need is driven by the need to identify the drivers of overdoses. And you mentioned to identify patterns and localities, and you gave an example about, the prescription of ADHD. I would benefit, and the committee would benefit, I think, for some additional examples of what those drivers of overdoses are that are only able to be identified using that identifiable data. Thank you.
We're happy to provide additional examples, and we can do so as well and follow up to this committee hearing as well. And I'm sure that Tricia Tilley, when she's completed testifying at the other committee has a list as well that she could provide. Other examples are with HHS data, we have a number of human service data sets that show a variety of risk factors for opioid abuse, but we do not understand the relationship between those variables with the variables within the PDMP. Again, this would be, we would have the ability at this point in time with this legislation to tell you what are those risk factors, from the other variables that we have within the data that would be able to use for this analysis. We could help you relationship between teen smoking, for example. We could look at other data sets that we have around Medicaid for other health conditions, and do they lead to an opioid abuse in relation to prescriptions? As you're well aware, people come in and out of Medicaid. I think it's designed that way on purpose. And so the Medicaid data set itself does not show us those patterns that lead to opioid abuse and misuse. The ability to combine this would allow us to help you understand a better picture at the individual level. I think from what Senator Sherman mentioned earlier with the now established the law last year to create the Overdose Fatality Review Board. I believe that board already has the ability to secure that on a one-off type of data, but those are case examples. Those are not looking at patterns in this data set in aggregate level and be able to make an informed opinion and to inform the public and yourselves about those different variables and risk factors that we experience in New Hampshire. So ultimately, it would all be de-identified. We would never share that with information without the constraints that it would be established by Senate Bill 45.
Further questions of Dr. Ballard? All right, so I have a couple, Doctor. As I read through the original bill, I don't see any penalty for revealing data that should not be revealed. Is there a penalty?
Senator, I think Melissa St. Cyr would be better to speak to that, but
Okay.
we as an agency have an obligation under the federal government anytime we would have a HIPAA breach. And if we have a process we must undertake when we have a HIPAA breach of any type of data. And if those were to progress, there are certainly penalties from the federal government that we have to be responsible for. Right now we are responsible for over 500,000 persons' results from COVID-19 data, as well as the sexual health data from persons from sexually transmitted diseases, including HIV and hepatitis C. And we take it very serious. Extremely serious, the privacy of every individual in the state, and this data wouldn't be treated any differently than those concerns we have right now.
And I'm not trying to suggest that the department doesn't, but we've seen examples of, not as much in New Hampshire, but the IRS data being used for inappropriate purposes in the past, and obviously with people having access to it. But let me ask a second question. It gets to your example of a child that may be prescribed, for instance, something like Ritalin. And if you de-identify on an individual basis, help me understand what you're doing. How does it affect that individual? And are you going to potentially intervene in that family? Because I'm having a hard time understanding the need to de-identify the specific individual if there's not going to be some intervention in that individual's life.
We were primarily thinking about the individuals that come afterwards, the teenagers that progress into adolescents and adults later. We do not plan to use this data to intervene at an individual level from this bill. The purpose is to actually understand what's happening and then allow you to have that knowledge to make the tools, whether it's a policy decision or whether it's directing how we spend and fund future projects to intervene. It would be a great help if physicians knew if they were diagnosing a new teenager with ADHD, if that actually had a risk for an opioid addiction, and what that would require us to counsel and do in this state. Right now, I can't tell you if that's happening or not, or what the actual trend is, because we do not have the ability to determine whether or not that a later condition diagnosis that we know about through the all-payer claims database or through the Medicaid claims database is a result of a prescription for an ADHD medication that we could learn about through using the prescription drug monitoring program, just as an example.
And you just can't connect the dots.
It's impossible, sir.
Because there's no identifiable back to an individual person.
That is correct, sir.
Okay. Further questions? All right, Dr. Ballard, John, if you could stay on the call, so if there are further questions, we can come back to you. That'd be great.
Absolutely, Senator Bradley. Thank you.
Okay,
Sir.
Go ahead, Trish.
Trish, you got to unmute yourself.
Thank you. Sorry. Next, we have Lindsay Courtney on the list. From the Office of Professional Licensure and Certifications.
She raised her hand. She's at the top of the list, Trisha.
Thank you. There, Ms. Courtney. Okay, you're all set.
Thank you. Good afternoon, Mr. Chairman, members of the committee. My name is Lindsay Courtney. I'm the Executive Director of the New Hampshire Office of Professional Licensure and Certification, which is the agency that administers the Controlled Drug Prescription Health and Safety Program, also known as the PDMP. OPLC is supportive of SB 45, specifically sections 2 and 5 of the bill would permit the office to enter into data sharing agreements with the Department of Health and Human Services to share PDMP data with the department for public health purposes only. So I will defer to the department to explain in greater detail how the department's access to PDMP data is essential for public health research. As I understand it, they would essentially take the data, take the identifiable data, marry it with their data sets, and then de-identify the data and perform public health analysis. But in short, the PDMP has valuable information that would greatly assist the state in its efforts to combat the opioid epidemic. Given the public health crisis currently impacting our state, OPLC supports this legislation, which would permit data sharing in very limited circumstances. OPLC recognizes that this proposed limited data sharing represents a change from the original bill's clear prohibition regarding data sharing. Since PDMP's creation, any changes to PDMP's prohibition on data sharing has been made after much conversation, collaboration, and in a calculated manner. OPLC fully supports such a process, as we certainly need to ensure privacy is adequately protected. I would like to emphasize that SB 45 represents the end result of much collaboration between stakeholders over the course of many months. And I wish to thank Senator Guida for his hard work in bringing this bill to fruition. The bill contains many safeguards to ensure the scope of data sharing is quite limited. The office may only share data with the department pursuant to a carefully crafted agreement that is subject to review by the Advisory Council. Additionally, the data may only be shared for public health purposes only. The department is not permitted to release identifiable data and may only retain data for 3 years under existing statute. To your previous question, Senator Bradley, there is a provision in Section 318B36 that makes it a Class B felony for any person who knowingly accesses, alters, destroys, or discloses program information except as authorized. And I do think that would apply, obviously, to the department and its employees. Additionally, a blanket data sharing agreement would not suffice. The department must make a specific request for data, setting forth a detailed explanation as to the basis for the request. OPLC supports these limitations on data sharing as set forth in the bill, and I believe it strikes the right balance between protecting the public through data sharing and respecting an individual's right to privacy. Thank you for the opportunity to provide comments. I'm happy to answer any questions that you may have.
Thank you very much, Ms. Courtney. Are there questions? Okay, seeing none. Thank you very much. Trish? You're muted.
I'm sorry, I keep doing that. Next, we have Mr. Neil Kirk. Okay. I believe that, Mr. Kirk, you can unmute now?
I unmuted. Can you hear me?
Yes. Good afternoon, Representative Kirk. How are you?
I'm well, thank you, Senator, and it's good to see you again and other members of the committee. For the record, I'm Neil Kirk. I live in Ware, and I'm representing myself. I support the bill as amended by 0028S, but I oppose the bill without that amendment. As John Williams said, I was part of one of the stakeholder groups that Senator Guida got together. And while this compromise was something that I agreed to, it's been some time, and I've had further opportunities to think about it, and especially in light of the recent constitutional amendment on privacy, I've had some significant second thoughts, hence my opposition to the bill without the amendment. As introduced, the bill would allow Health and Human Services, the department, to individually identifiable personal information of everyone who has had a controlled drug prescription filled in New Hampshire. It doesn't apply to those of us who buy our prescriptions out of state online, and report it to the PDMP. It's basically a data dump. And as Senator Rosenwald said, it's not just opioids, it's Viagra, penicillin, Ambien, and Ritalin. And I doubt very much that the people of New Hampshire want the Department of Health and Human Services to have access to their controlled drug histories. For many of us, it's bad enough that the
PDMP.
Thank you, PDMP learns of our non-opioid prescriptions. The PDMP was created to reduce doctor shopping by drug abusers. It wasn't intended as a database for public health research on identified individuals. And this is a traditional example of mission creep. You create a database for one purpose, and somebody else says, gee, wouldn't it be nice if I had access to that data? And the original purpose gets expanded. Health and Human Services could accomplish some of its objectives if we were to use a random number generator and give every individual whose information is in the PDMP a unique identifying number. This would allow the department to track people as they got new prescriptions and over time without knowing who they were, just a number. So I would suggest to Mr. Williams and other folks at the department that they consider that. And I think that would be allowed under current law. But if not, certainly an amendment could be proposed to that effect. As was said before, the current PDMP prohibits, and the amendment, excuse me, the bill prohibits the department from contacting any individuals. But just as with mission creep before, there will come a time when they want that changed so that once they discover something, they can help the particular individual by contacting them. I guess my conclusion is that this is an unnecessary broad intrusion into personal and private information, and it's contrary to the intent of the recently adopted Informational Privacy Amendment to our state's constitution, which says an individual's right to live free from government intrusion in private or personal information is natural, essential, and inherent. So regardless of Let me put it this way. This is not the time to expand the responsibilities of Health and Human Service Public Health Bureau. At this time, they don't have the human resources to use this material, and they're preoccupied in dealing with the public's health in the midst of a pandemic. Senator Guyder's amendment solves this problem, and I urge the committee to adopt the amendment and pass the bill as amended. Thank you, Mr. Chairman. I'd be pleased to answer any questions that members may have.
Are there questions of Representative Kirk? Thank you very much, Neil. Good to see you, hear of you again, and stay in touch.
Thank you, Senator.
Okay,
Great.
next on the list, we have David Strang.
Good afternoon, Dr. Strang.
Good afternoon, Chairman Bradley and senators of the committee. Can you hear me?
Yes.
Yes.
Wonderful. My name is Dr. David Strang. I'm an emergency physician, and I was instructed to sign in as state agency staff as I am the chair of the Advisory Council for New Hampshire's Prescription Drug Monitoring Program, or PDMP, and have been for the last 7 years. But I want to be clear that I'm not speaking on behalf of that entity, as this bill has not been reviewed by the Advisory Council since the date of our last meeting was October of last year. In a related effort already described by Senator Guida, there are plans supported by Governor Sununu to move the PDMP from under the umbrella of OPLC to that of DHHS. Given that is likely to come to pass, I have grave concerns with this bill allowing DHHS to take PDMP data for its own use. I have an historical perspective that you all must become aware of. In April of 2019, Senator Bradley asked me to work with Mr. John Williams, attorney for DHHS, in crafting an amendment to a piece of legislation introduced by Representative Bill Marsh that would have allowed sharing PDMP data with DHHS for the purpose of producing aggregated de-identified reports. And that legislation was House Bill 369 at the time. We had 48 hours to get this done. I had an immediate problem with the language of this amendment written by Attorney Williams, as it stated only, quote, de-identified data, end quote, would be shared with DHHS. When I explained to Senators Bradley and Sherman, as well as Representative Marsh, that this was at best misleading, that in fact, patient-specific identifiable data would be sent out the door to be shared with DHHS to be combined with their patient-specific identifiable data, and only then would it be de-identified and aggregated to a person. These three elected officials told me, quote, that's not what was represented to me. I don't like that idea at all. Mr. Williams was very hesitant to correct this misleading language, to which I replied, I would not be part of an effort to correct or to mislead the members of the House and Senate in order to make this legislation succeed. Now, to his credit, he did remove this misleading language, but the process was moving too fast without public comment. In other words, without enough disinfecting sunlight, and thus Senator Bradley tabled this amendment. In response to this, at the PDMP Advisory Council, we agreed to form a data sharing subcommittee to specifically look at this issue and make recommendations to the Board of Pharmacy on the feasibility of such a mechanism. Remember, at the time, the Board of Pharmacy housed PDMP before it was moved to its current location of OPLC. Senator Guida, who at the time was not, but is now a member of the Advisory Council, was an important element of that effort. These meetings took place over the summer of 2019. Imagine our surprise when we learned that behind our backs, DHHS had been meeting with the program manager of the PDMP that spring and summer to make an application to the CDC. Then in exchange for their grant money, the PDMP would turn over this patient-specific identifiable data to DHHS and ultimately the CDC. Despite this being a violation of New Hampshire law encoded in the enabling legislation that created the PDMP in 2012, the program manager contributed to this grant application. Once this was discovered, she was given a cease and desist letter from the Attorney General. What made this letter more ironic was that at the time, she was being defended by the AG's office in a suit brought by the DEA that was demanding the PDMP turn over this same patient-specific data to that federal agency. The take-home message for those of you listening to this testimony is that there are many entities, both state and federal, that want this private prescription data. Having had two very negative experiences with the New Hampshire DHHS, I do not feel that they have demonstrated the trust necessary to share this private individual data with them, regardless of what private data they already have on these New Hampshire citizens. By passing this bill, you will put the fox in charge of the henhouse, and we all know the outcome of that age-old analogy. I urge you to extract any reference to data sharing between the PDMP and DHHS in this bill, but leave intact Roman numeral 4 on page 2, lines 10 through 32, as this is necessary housekeeping changes to the PDMP that I do recommend you support. Thank you for taking the time to listen to my concerns, and I'll be happy to take any questions that you may have.
Are there questions of Dr. Strang?
Looks like Senator Sherman has a question.
I'm sorry. Yep, Senator Sherman.
Thank you, Mr. Chairman. And thank you, Dr. Strang. Good to hear you again. So I have a question. If your advisory council, if anyone were to come and ask for specific data on any of the people within, there's actually three groups that you oversee within the PDMP. There's the pharmacists, the doctors, or the providers, and the patients, unless you correct me that I'm wrong about that. If anyone were to come and start asking for data, are you bound by statute not to release that except under certain circumstances, like what would that be, a subpoena or some court action? Or do you have the ability now, if a reasonable request that had specific data requests, could you release that now as the PDMP, or is that only allowed under statutory limitations?
The only entities to which this data can be released is to providers and dispensers by virtue of access to the program, and to a specific patient because the bill does allow them to request their own data. Those are the only entities that were originally envisioned as needing access to this data. Now, the original legislation, again, this was, I believe, SB 286, signed into law in June of 2012 by Governor Lynch, actually prohibited law enforcement from having direct access. We have changed that to allow the Office of the Chief Medical Examiner to access that data for the purpose of completing a comprehensive autopsy. That's really the only amendment that's been made that allows access to the program. So in a roundabout way, Senator Sherman, the answer is no. There really are no other entities that are allowed access besides dispensers, providers, and under a written request, patients.
Senator Sherman.
Yeah, just a quick follow-up and more, I'm curious, with this new drug overdose fatality review committee, council, which is, I believe, a protected group. In other words, they are protected by confidentiality, and the right to know doesn't apply to them, similar to some of our other ones that have to do with people who died. Would they have access to that if the patient on the PDMP has died? Would it have to be requested by the medical examiner, or could that group do a request as part of their review of that mortality?
The advisory council became aware of this due to my reporting to them when we first learned about this on the opiate prescribing advisory council, which I'm also a member. And we discussed this access and particularly with Attorney Courtney, who is now the executive director of OPLC. And we felt that the only way this data could be accessed would be via the medical examiner's office, which has a seat on that fatality review commission.
Okay, thank you.
Further questions of Dr. Strang. Senator Whitley.
Just a housekeeping question, actually. Thank you, Mr. Chair. Dr. Strang, that you had mentioned some housekeeping things that you did think were appropriate. Are those in, I don't know if you've seen Senator Guida's amendment or Senator Rosenwald's amendment. Are those housekeeping changes in that new amendment?
I have actually not seen that amendment, so I can't answer that. Specifically, what I was referring to was where it amends RSA 318B31 Roman numeral 4 to change the definition of dispenser, also clarifies what licensed hospital pharmacies can do, so on and so forth.
I think he's referring, Senator Whitley, to Section 3 of the original bill, and I think also Section 4, because they're both those sections now under the Guida Sherman Rosenwald Amendment are Section 1 and 2 of the amendment.
Thank you, Dr. Strang. Thank you, Chair.
Yes, the version I'm looking at is, it's entitled 21-0834, and it says 10/05. So that I think is an older version.
Further questions of Dr. Strang? Seeing none. Thank you.
Thank you very much.
Okay. We do not have any more speakers signed up, Senator Bradley. If anybody would like to add anything, they could raise their hand virtually. If you're on.
John or Dr. Ballard, is Ms. Tilley available or not?
I'm looking on the list. I do not see her on the list. Senator Rosenwald has her hand raised.
Senator Rosenwald.
Thank you. I would just quickly comment that the comments from Mr. Williams and Dr. Ballard are about the security of this information, but really the amendment that we've brought forward is about privacy. And so it's the difference between what you protect and how you protect it. We are not so concerned about the security. This is really about privacy of 85% of the population. Thank you.
Okay. Senator Guida has his hand raised.
Okay. And then I have another question for Dr. Ballard.
Okay.
Go ahead,
Senator
Senator
Guida.
Guida.
Thank you, Mr. Chairman. I think it's instructive that while the department is keenly interested in gaining access to this to stop the quote unquote opioid crisis, in their own terms, they've described a 60% reduction in opioid deaths over the last 2 years. The program is working, and part of the reason it's working is the current means of administering and the access of data in the PDMP by providers and dispensers. And so, again, there's no urgency here, and we certainly don't say never, but in light of the move to HHS and in light of the temptations and the seeming inability to resist those temptations from time to time, I think we owe it to our people of the state to err on the side of caution, move it to HHS, and then let's develop a set of protocols going forward from there very clearly and deliberately. But to move it and change the protocols at the same time, I think is unnecessary, and I think puts at risk the privacy of that information. Thank you.
Thank you, Senator Guida.
Okay.
Trish, if you could bring up either John Williams or Dr. Ballard.
Dr. Ballard, you can go.
Thank you, Dr. Ballard. So there were two questions that came as a result of some of the testimony. And my first question is, could the original version of Senate Bill 45 be amended to restrict the sharing of information for those drugs that are illegal drugs as opposed to legal prescriptions?
Senator Bradley, thank you for that question. The prescription drug monitoring program includes drugs that are legally prescribed. They may be illicitly used, but they are legally prescribed. So I don't believe amending that bill would change our ability to understand the relationship between these legally prescribed drugs and, for example, the other data sets we have that show illicitly used data, or excuse me, illicitly used drugs and illegal drugs. So I don't believe that that change would accomplish the public health abilities for us to understand the root causes and the progression, as an example, in the opioid epidemic.
Okay, and my second question is, Representative Kirk had a suggestion about a random number generator. Is that something the department has considered?
We have considered this just in conversation, but the only way it would work is if we did a random number generator of the PDMP data set with the same other data set that we're trying to understand those patterns from, with the same random number generator applied to that data set, and then combine the two randomly generated numbers. In a sense, that's what we would be doing behind the scenes anyway to understand the patterns of the opioid epidemic. But I'm not certain that that would be legal as was previously mentioned as potentially possible. The CDC tells us that the information that would be used, that we would use to understand the behavior of the epidemic and to inform and evaluate interventions that we're doing. I don't think that we would be able to do that type of a goal with randomly generated number sets from the PDMP when we wouldn't be able to have the connections with the for example, the Medicaid data set.
Okay. Senator Sherman.
So just following up on that, Dr. Ballard, just to be as clear as I can possibly be, what you're looking to be able to do is you may have already a data set in your system, maybe a data set including Medicaid data that you have already in your system. You have names, you have all the data on an individual patient. So now what you would be considering doing would be looking for that patient in the PDMP to try to understand their pattern of behavior, which is why a random generated number would not help, because once you do a random generated number, you can't go back and query the PDMP for that specific patient. So you would be taking Tom Sherman, your Medicaid patient, going into the PDMP and looking for Tom Sherman's prescription controlled substance or controlled drug prescription history and trying to answer a question about the progression of Tom Sherman's use. By the way, I'm not in the PDMP. Tom Sherman's use of a controlled substance all the way to your database. Is that the idea? That's why you need to know, that's why you can't have them de-identified when you go to query the PDMP.
That would be an example, yes, sir. The department, for example, funds through substance use disorder treatment centers, treatment for all individuals that are unable to afford it, obtain it by them on their own. And so we have that outcome data, but we don't know what happened before that. So we already know someone has a substance use disorder. We have that data set. It's very, it is privately held data. We do also maintain the security of it, but we don't know what happened that led to the state and the department needing to provide those services for those individuals. And so we could now understand that trend of what happened, not at an individual level. We're not, that is not our intention at all, the individual, but overall for the state and those persons that have those outcomes that led to over 200 persons dying last year, and particularly young persons where there were many life years lost. That's truly tragic for the state.
Further questions? Okay, seeing Senator Sherman.
Just one more. If these are in your database because they are either in these programs or on Medicaid, would you not already have their prescription pattern through your Medicaid database?
We do not, sir. Many of these persons do not have data in the Medicaid database, plus persons come in and out of Medicaid.
Okay.
It would be only available in the Prescription Drug Monitoring Program database.
All right, thanks.
Further questions? Right, Trish, I think that concludes.
Yes.
So is there anybody in the public that wants to speak? Please raise your hand or *9 on your phone.
Okay.
Okay.
I don't see anybody, Senator Bradley.
Excuse me?
I don't see anybody raising their hand.
Okay, great. Thank you very much. I'm going to close the hearing on Senate Bill 45, and we'll open the hearing on Senate Bill 29, and welcome back Senator Guida.
Okay. Okay, Senator Guida, you're all set. Senator Guida, you can unmute now.
Yeah, I'm finding the bill here. I'm scrambling, technology challenged.
Okay.
Well, Bob, if I can do it, you can do it.
Don't bet on it.
But guess what? I have 3 really capable staffers keeping me on the straight and narrow. As I always say, the geniuses.
All right.
Would you like us to send it to you?
Yeah, that would be very helpful.
And we'll send it.
Griffin.
Now, where are you sending it to?
Griffin, you're muted.
I'm on it. Give me 1 second.
Okay, I've got it. I actually found it.
Okay.
All right. Thank you, Mr. Chairman and members of the committee, for your patience. This is a bill. Understand that I have, since my first term in the House in 2001, strongly supported the use and expansion of use as medically necessary of medical marijuana. And we have begun to provide this service to those who are needy of the relief that it brings. I'm extremely concerned, based on the remarks of the Surgeon General of the United States, that there is absolutely no regulation whatsoever over the concentration of medical marijuana, and it varies substantially. 17 to 27%, I think the number is. And so what this bill would do, because this is medical marijuana, this is not recreational, all right? It would introduce a level of science and frankly, practitioner oversight into the administration to a patient of medical marijuana. This bill would establish a threshold of 10% by volume or concentration of THC, above which a doctor would have to state the reason that the higher concentration is required. I do this because we have a number, I believe the number is over 20, of those receiving medical marijuana today who are under the age of 21. And the harm caused by marijuana, THC, in strong concentrations is known and documented to cause harm to the brain up to the age of 26. So this is an effort to protect our younger people by simply saying that we want to have a doctor ascertain that the condition that they're being treated for, 10% would not be adequate, and they would therefore permit a higher concentration. It's in the effort to try to protect our young people from the unquestionably harmful effects of high concentrate marijuana, even if they're being treated for a medical condition. It doesn't preclude it. It just says, let's take a careful look at this and see if it's really necessary, because it does definitely cause harm to the developing brain of people up to the age of 26. I would certainly ask any or answer any questions.
Are there questions of Senator Gaida?
I have one.
Senator Sherman.
Do we know, thank Senator Gaida for introducing the bill, and just wondering, do we know if our dispensaries actually sell the more concentrated versions in their products already?
I do not know the answer to that, Senator.
Okay. And can I ask a follow-up?
Yep.
I didn't look to see if Mike Holt was on this, but in general, over the last couple of years, any changes to the therapeutic cannabis legislation? I've kind of wanted to get the input of the, hold on a sec, the Therapeutic Use of Cannabis Advisory Council.
Michael Holt is on the call.
So I'm just wondering if this has gone before that group, which really, of anybody in the state, they have the broadest perspective of what's happening in the dispensaries and within the statute. So have Senator Gaida, have you talked to the council at all about this?
I have not.
Okay.
Further questions? So Senator Gaida, I have one. Are there any other states that allow this exemption?
There are other states that in fact put this this type of protection in place. I think the number is, it's either 13 or 17, but I can verify you and get back to the committee. But again, the concern is not to deny the relief. It's to protect the young people whose brains can be seriously impacted by the high concentrations.
Okay. Seeing no further questions, Trish, why don't we get the department or Mr. Holt or John Williams? I see they're on the list.
Yes, we have Michael Holt. You can unmute now, Mr. Holt.
Good afternoon, members of the committee. My name is Michael Holt. I'm representing the Department of Health and Human Services. I am the administrator for the Therapeutic Cannabis Program. Our position on this bill is neutral. However, my testimony is informational, but we do have some concerns about the bill, about the implementation of the bill, as well as some technical issues. To answer the specific question already posed about the TCMOB, the Therapeutic Cannabis Medical Oversight Board, they meet monthly. They have not seen, to my knowledge, the language of this bill. It was published last Thursday. The hearing is today, and my initial recommendation would be to bring the board in to see if they have an opinion on the clinical aspects. This kind of bill is exactly what the Therapeutic Cannabis Medical Oversight Board was authorized to provide an opinion on. They meet monthly. The next meeting is on February 3rd. We can bring this to them, or I can bring this to them, working with the chair for that meeting. I can't say whether or not they will have time enough to come up with a definitive opinion on this, but I can certainly bring it to them if that is the request of the committee here.
Yeah, I think that information will be helpful. Are there questions?
Okay. Well, I do have additional testimony if you don't mind.
Go ahead. I thought you were done. My apologies.
I was just answering the first question posed. As we know, the bill would establish a THC concentration limit for qualifying patients under the age of 21, and it establishes an administrative process for certifying medical providers to request an exception to this limit. So let's talk about the provider exception process first. First, there's a technical clarity issue here. It's unclear if the bill envisions one or two processes for this provider's exception. Page 2, lines 1 to 3, establish an exception if the provider indicates a terminal condition on the written certification. It's unclear if lines 4 through 17 establish an additional separate process for non-terminal patients, or if these lines describe the process intended for terminal patients. So that's a question for the sponsor, and it could be fixed through some language edits. Regardless of the answer to this question, the process described is going to be burdensome to providers, potentially prohibitive. The bill requires what I would call a prescription-level knowledge of cannabis products and cannabis therapy, as well as documentation of that knowledge on behalf of providers. We know that a hallmark of New Hampshire's cannabis law is that this is not a prescription. Providers certify a patient's condition. They do not prescribe cannabis. Requiring providers to establish in writing potency, dosage, routes of administration, anticipated benefits is a tantamount to a cannabis prescription, and that will be a fundamental change to how the program currently operates in New Hampshire. I would suggest that it's certainly unknown, but I would suggest that that providers would unlikely participate in this process, due to being administratively burdensome, insufficient education among the provider community in cannabis science to meet the documentation requirements, and being required to essentially write a prescription for a federally illegal Schedule I drug. In addition, the bill requires medical records and documentation to be sent to the department. The department does not have clinical staff employed by or available to the TCP, the Therapeutic Cannabis Program, to clinically evaluate medical records in order to approve or deny such requests. We don't have the staff. We don't have adequate staff to review these records, whether or not to approve or deny. Let me note that there is already a process established in the program's administrative rules for providers to relay dispensing instructions to the ATCs regarding these elements, like potency, dosage, routes of administration, as well as any other instructions. Administrative rules require the ATCs to comply with such instructions if they receive those instructions for a particular patient. They would be prohibited from dispensing a high-potency cannabis product for a specific patient if the certifying provider told them to. This is something that we inspect on at our annual inspections. So based on the above, I think we should assume that most patients in this age category will not get an exception. They will not be terminal, and the patients won't have the providers won't be issuing this documentation. So what does that mean for the ATCs being able to continue to serve this population at all with their current product lines of cannabis flower and cannabis-infused products? The intent section of the bill states that 84% of New Hampshire's ATC's products are greater than 15% THC, but the bill sets the potency limit at 10% THC. So I think we can expect this bill to impact even more than 84% of the ATC's product lines. I can't confirm or deny those numbers or those percentages. I'm just going based on what the bill says. So in order to continue to serve this population with a full selection of strains and products, ATCs will have to create substantially different product lines, both strains of cannabis, flower, and CIP, cannabis-infused products. It's unknown whether this is possible for the ATCs, either financially or in terms of available production capacity. If it's not viable, then this bill is going to effectively deprive this age population from accessing the New Hampshire ATCs, People in this age group may well choose to purchase cannabis from illicit or gray market sources like Maine's unregulated caregiver network, over which the state of New Hampshire has no regulatory oversight for quality, safety, testing, labeling, and education. So those are the basic concerns that I have with the bill. There are a number of technical editorial issues. A couple we've already mentioned. It's unclear if there's two processes or one for the exception process. The department doesn't have clinical staff to examine these medical records to make an approval or a denial. There's terminology issues. Current law uses the term cannabis, but the bill uses marijuana. Law uses the term qualifying patient, but the bill uses qualified patient. Two of the requirements for the provider's exception request seem contradictory or redundant. It's unclear if the bill intends to require providers to document both an insufficient dosage and a sufficient dosage. These are page 2, lines 8 and 9, and well as lines 12 and 13. So that needs to be clarified as well. In addition, the department's approval time frame for these requests are 14 days, but the time frame in current law for the department to approve or deny an application is 15 days. Again, that time frame should be made consistent. That's on lines 18 and 20. Lastly, the bill requires the department to create an electronic exception form, requires providers to use that electronic form. Building an electronic submission capacity will have a fiscal impact that has not been identified. There was no fiscal note associated with this bill. Again, fixing that issue to allow a paper process would eliminate that concern. By way of some age data, I'll just offer that currently, well, as of 6/30, like our last annual data report, program has a total of 10,688 registered patients. There are 10 minors on the program, so from 1 to 17 years old, you have 10 minors on the program, and adolescents aged 18 to 20, which is the subject of this bill, there are 53. So there's a total of 63 individuals as of our last data report that will be impacted here. So that's my testimony. I'd be happy to answer questions if you have any.
Are there questions of Mr. Holt? All right. Suffice it to say, I think the committee would probably like to hear what the advisory council has to say on February 3rd. Oh, that's a thumbs up, not a question. Right, Tom? Okay. Trish, go ahead.
Okay, our next speaker is Dr. Strang.
Welcome back, Doctor.
There he is. Okay.
Welcome. Thank you. Can you hear me now?
Yes.
Yep.
Good afternoon, Chairman Bradley and senators of the committee. Again, I was instructed to sign in as state agency staff, as I was for my earlier testimony this afternoon, as I am the chair of the advisory council for the PDMP. But I want to be clear once again that I am not speaking on behalf of that entity, as this bill has also not been reviewed by the advisory council. But as the PDMP was formulated to address the opioid crisis in New Hampshire and drug abuse in general, and as marijuana is an abused substance, I was asked by Senator Guida to speak on behalf of this bill. I am in favor of this legislation with the following caveats. It is clear that the main purpose of this bill is to allow the use of high concentration THC products with some oversight by DHHS. At the very bottom of the last page, item C, that's lowercase c, states the department shall approve, not may, but shall approve the request within 14 days after receipt of the complete documentation required. It then states that the request shall be deemed approved if DHHS fails to act on the request. That's not oversight, that's a rubber stamp. All one would need to do is file some paperwork with DHHS and the use is automatically approved. DHHS wouldn't have to do anything, and given that government often takes the path of least resistance, they likely wouldn't. They would simply collect the required paperwork. I would suggest that you amend this language to read, quote, The department shall rule on the request within 14 days, end quote. And also amend the last sentence to read, quote, the request shall be deemed unapproved if the department fails to act within 14 days, end quote. This would require DHHS to actually provide oversight of the use of high concentration THC products, which by virtue of their name would have higher potential for adverse effects and abuse. Finally, I would urge this committee to look into the requirements that THC concentrations be listed on all marijuana-related products approved for, quote, medicinal use. There is a fallacious belief that simply because THC comes from a plant that it is, quote, natural, end quote, and therefore healthy. Let me remind you that the chemotherapy agent Taxol comes from the yew plant. Aspirin comes from the bark of the willow tree, and the cardiac medication Digitalis comes from the foxglove plant. All of these agents are poisonous if taken in unregulated, excessive doses. If I instructed a patient with heart disease to chew a few leaves from a foxglove plant, I could be an accessory to their death. Please keep that in mind when you consider any marijuana legislation and consider requiring concentrations to be listed on all THC containing products. Thank you for your time, and I would be happy to answer any questions that you may have.
Are there questions of Dr. Strang? Seeing none.
Lastly, Senator Bradley, if I could just mention, Mr. Holt referenced a line on page 2, the dosage and administration route insufficient to provide relief. I believe that envisions in this application listing what dose and route hasn't worked, hence they would like permission to use higher concentration THC. So I believe that is correctly written. They're simply looking for why a higher concentration is necessary for the patient for which they're applying.
Okay. Okay, any further questions of Dr. Strang? I don't see any. So I know Senator Guida wanted to speak a second time, but Bob, let's get through all the testimony first. So Trish?
Yes, we have 2 more speakers signed up, and the first one is Catherine Frye.
Hi, Kate. Go ahead.
Good afternoon, members of the committee. Thank you for hearing my testimony today. So I just want to state that New Futures is in support of the kind of the idea behind this bill, and that's the idea that we really need to be cognizant that high level potency products that are being sold in the ATCs. But I also 100% want to say and make sure the committee understands this, that we do support the Therapeutic Oversight Board reviewing this, as well as some of you may recall New Futures worked with the sponsor of this legislation, Senator Martha Fuller Clark, to put together this oversight board because there was really no discussions regarding adding conditions and looking at the science behind it. And although I think the department was a little nervous about it at first, I think we can all agree it's worked out very well. And there's been a great robust discussion around the science. So I would 100% agree that they should look at this bill. But there are a couple things that I do want to say in general is that we have to understand that the potency of marijuana has really increased over the years. And these products, you know, it's less about the flower and these higher concentrate products such as edibles, waxes, dabs, and shatters. And I will say, according to the annual report by the Therapeutic Cannabis Program, to answer an earlier question, all 3 centers do sell these products. And if you do go to the website, under their menus, you will see the breakdown of the THC. Some are as high as 95.6. So these products are in the alternative treatment centers. I just wanted to answer that question. And so there are concerns about this higher level potency. We have to understand that there can be side effects, especially to youth. Marijuana use directly, as you all know, affects the brain, especially those who have developing brains like young adults and children and teens. So it is important to look at this increased potency, but I do agree with what Mike Holt had said earlier, the way this bill is written and how it would kind of change the idea of that, you know, the provider is now prescribing in some ways, and that was never the idea behind the creation of the therapeutic cannabis program. It's really just for providers to certify that they have a certain condition. So I also think it would be helpful. I do know that, as Mr. Holt said, there's probably about 50 individuals who are under 21. It would be helpful for the department maybe, or the ATCs, to analyze what type of products are being used by this population, just to get in concern if this higher concentrate like shatters or waxes or something that is indeed being sold to this population. It may not be an issue at all. So I think between the department teasing out that information and the having the oversight board review it, it would be very helpful to know what the next steps are. I do just want to say that I do think we have to be mindful of the potency of some of these products, and make sure, especially if we go in the direction of adult use, that we have some strategies in place that really help us create a safe environment for teens and young adults.
Thank you, Kate. Are there questions of Ms. Frye? How's your daughter doing?
She's doing pretty well. She's out in Oregon.
Good. Glad to hear that. A freshman in college, just so everybody knows, and really, she was so instrumental in getting legislation passed last year. I think she continues to deserve a shout out.
Thank you, Senator.
I agree, absolutely.
Thank you.
Okay, Trish, go ahead.
Yes, our next and last speaker signed up is David Cyrek. I do not see him on the list. If you are, okay, I think he's raised his hand. If you are with us, David Cyrek. Is this Mr. Cyrek?
Yes. Hi, how you guys doing?
Okay. Hi.
Good afternoon.
Hi, how are you? Hey, how are you guys doing? My name is Dr. David Cyrek. I'm the medical director for Sanctuary ATC. I thank you for the opportunity to speak. And you know, I'm pretty much opposed with this bill. Just let me start that, you know, when the therapeutic cannabis program became legal in New Hampshire in 2013 under the governorship of Maggie Hassan, I believe, as many do, that the intent was really never to somehow impede or make cannabis restrictive in any form or fashion to patients that really need it. I think is, oh, can you hear me?
Yeah.
Hello? Okay, yeah, oh, so I'm sorry. Okay, I'm sorry. I thought I chopped out. I apologize.
No worries.
Yeah, and so that's sort of what this bill does, is it really makes it prohibitive for this younger population to access sometimes this stronger form of medicine that they need to treat their symptoms in the disease state that actually got them into the program in the first place, right? So just a little history, Sanctuary ATC, only about 0.6% of our registered therapeutic cannabis patients are under the age of 21. And of these patients, a fair amount don't even use THC, the psychoactive component to the cannabis plant. What they are purchasing is either CBD, which is known as cannabidiol, I'm sure you guys have heard that, and also THCA, which is the acidic form of THC, which is non-psychoactive as well, because the acidic form can't pass the blood-brain barrier to actually affect any psychoactivity. So what these patients are using, these younger patients under the age of 21 are using these for are seizure disorders. So both CBD and THCA has been helpful to help with specific seizure disorders and to cut the amount of seizure activity down. So this bill really wouldn't impact them anyways. And to be honest, yes, some of our other younger patients who are accompanied always by their parents, and their parents are always educated as to what products they're picking up and to what percentage of THC these products do have. They may be purchasing, some of the higher concentrates that Kate mentioned, some of the shatter or some of the waxes, but often their parents cook with it. And what this does is this actually helps them save a lot of money. Because if you take a high concentrated THC product and you make, for instance, 45 cookies, each cookie is actually not that potent. It's actually probably 10% or less in terms of THC, which is kind of what this bill is opting for. So a good fair of our patients actually do that. They bake or they cook with these stronger concentrates to save money. Because as you know, cannabis is pretty expensive. And, if they purchase 45 cookies, for instance, at the dispensary versus making 45 cookies at home, they can save hundreds of dollars, which is important and critical to these patients that may be financially strapped from these, their children that are on these very expensive medications regarding seizures or some of the other disorders that they may be occurring. And just in defense of the patients who are under 21 who may be using higher concentrates, either in their full form or making maybe more potent edibles, they may not be terminally ill, but this bill will negatively impact them because a lot of them have severe disorders such as Crohn's disease, Tourette's syndrome, and severe seizure disorders such as Dravet syndrome, where higher THC doses helps not only their symptoms, but also helps outbursts of anger, helps calm them down. I've heard, through parents that before they started the program, their children would, kick the TV, break the TV, kick the dog, whip things around the room. And then when they started, having sort of higher dose edibles, it really calmed them down when they were able to relax these patients and actually get these patients to relax and they get a good night's sleep, which is important, not just for the patient, but also for the whole family. So, I guess this bill, there's a lot of flaws in this bill, the way it's worded, as Mike Holt pointed out. But I just think you guys need to see that, THC should not be demonized, because in using the right setting, it's very safe, and it can really help these patients with, very severe disorders that, traditional pharmaceuticals and therapeutics failed. So that's kind of my take on it. I know I don't have, any personal experience or have no clue how it is to have a child that has a severe syndrome disorder, such as Dravet syndrome or Lennox-Gastaut syndrome, where they also have significant cognitive dysfunction and behavioral dysfunction. And sometimes the higher dose THC and some of these higher concentrates can really help them in terms, like I said, calm them down, almost like how Ritalin would calm a young child with severe ADHD. So I don't think it necessarily should be demonized. I think if it's used in the right fashion, cannabis and even some of the higher THC concentrates can be very helpful and therapeutic for some of these patients. Any questions?
Yeah, questions of Dr. Cyrek? Seeing none.
Okay. Well, thank you for hearing me.
Thank you very much. So now Trish will recognize Senator Gaida for a second time.
And we did have one more person sign up. Mr. Light, do you want to hear from him first?
Sure. Mm-hmm.
Mr. Light, go ahead.
Yes, this is John Light again. Again, speaking only on behalf of myself from Manchester. Thank you again for the opportunity to speak. So I'm here to oppose SB 29 for two reasons. The first reason that I oppose the bill is the generally paternalistic nature of the bill. It is true that some people who consume cannabis may experience some negative side effects, but this is true of practically all substances, even water. which humans need to survive. Yes, it is actually possible to drink too much water and become seriously ill. The condition is called water toxemia. And yet we do not require permission from the government to drink excessive amounts of water. Why then should we require permission from the government to consume allegedly excessive amounts of THC? In any case, increased concentration of THC doesn't necessarily equate to increased danger to the user. The same way you might drink a full bottle of beer, but only a shot of gin, a medical cannabis user might smoke a full joint worth of low THC cannabis, but only a small vaporizer dose of higher concentrate cannabis. The relevant information here is not the potency alone, but the potency in combination with the specific dose and method of ingestion, which this bill does not explicitly take into consideration. The second reason that I oppose the bill is the seemingly arbitrary age limit imposed for consuming allegedly excessive amounts of THC. Although the statement of intent points to the Surgeon General's warning that there is risk to the brains of adolescents ranging from age 12 to 25 years old, the bill puts the age limit for requiring a permission slip to consume these allegedly excessive amounts of THC at 21 years of age. Are the brains of 21 to 25-year-olds not as important as those below 21 years old? What is the rationale for the 21-year-old age limit when the Surgeon General's warning cited in this bill states there is a risk up until the age of 25? In any case, adults aged 18 and older should be free to consume substances with allegedly excessive amounts of THC as they and their healthcare providers see fit, without the need for an exception from the government. For these reasons, I ask that you reject this bill in its entirety. Thank you for your time, and I'm happy to take any questions.
Thank you, Mr. Light. Are there questions? Seeing none. Thank you again.
Thank you.
Okay, and now Senator Gaida for a second time.
Yes, Senator Gaida, you're all set.
Thank you, Mr. Chairman, members of the committee. I'm very willing to work with Medical Oversight Board, the Cannabis Board, and so forth to develop this. But to state, as a state, that we restrict 21-year-olds, under 21-year-olds from purchasing cigarettes or alcohol, and then to allow the unfettered, unregulated use of something that is unquestionably scientifically proven to be harmful to the human brain developing, I think leaves us open to criticism in our responsibility to the public health. I said I'm willing to work with folks. The Surgeon General's warnings are based on science. The concentrations, we don't deny, as a previous doctor stated, we don't deny anyone the ability to access high concentration THC for therapeutic purposes, medicinal purposes. What we do is just establish a level of caution so that we don't do any harm without taking a good conscious look at the concentration that we're giving to folks up to the age of 21. Why 21? Because 21 is the age of majority. And a person at that age is assumed to have the sensibilities to make their own decisions. So what we're doing here again, right now it's a free-for-all. There is no regulation and no restriction. It's anybody's guess. And I think the state has an obligation to protect those young children, not many of them, roughly 60, whose physical ailments, they require concentrations greater than 10%. But I think whose oversight by the medical prescriber or the medical doctor who allows it or recommends it would be a prudent maneuver. So again, I'm willing to work with the agencies to make this a better bill, but I think it's an oversight we need to take a look at. And I ask the committee's support for this legislation and willing to amend it going forward.
Questions again of Senator Gaida? Okay. Seeing none, are there any members of the public that want to testify on Senate Bill 29?
I do not see any hands raised.
Okay, in that case, I will close the hearing, but I will entertain a motion to go into executive session.
So moved.
Been moved by Senator Avard. Is there a second? Senator Sherman is seconded. So every motion has to have a roll call. I will call the roll. Senator Gray,
Yes.
Senator Sherman,
Yes.
Senator Whitley,
Yes.
and Senator Avard.
Yes.
Okay, so we are now in executive session. I think we probably could take up Senate Bill 34 if somebody wants to make a motion. Senator Sherman,
I move ought to pass.
I'll second.
Senator Sherman moves ought to pass on Senate Bill 34. Is that seconded?
Second from Jim Gray.
Seconded by Senator Gray. Is there discussion? So I would just note that this was a bill that the Senate passed last year. I think both Senator Sherman, Gray, and I remember it. It obviously got caught up in the COVID situation in the House, but I see no reason not to move forward with it. So if there's no further discussion, I will call the roll on the motion of ought to pass, starting with Senator Avard.
Senator Avard, yes.
Senator Whitley,
Whitley, yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
and I vote yes. Is there a subsequent motion?
Consent?
Second.
Senator Sherman has moved consent, seconded by Senator Gray. We'll call the roll on that. Senator Gray,
Yes.
Senator Whitley,
Yes.
Senator Sherman,
Yes.
Senator Avard,
Senator Avard, yes.
and I vote yes too. And Senator Whitley, as a new member, not a returning member, you get the honors of the blurb that staff will help you write.
Okay, will do.
Thank you. Okay, let's have a discussion about the other two bills. Senator Sherman, what's your thought on Senate Bill 45? The PDMP bill, because your name's on the amendment.
Yeah, so I also worked with Senator Gaida, and we worked on making this open to HHS. I have some concerns that, and they are about privacy. Once the PDMP is, if it is actually moving out of DHHS, and I don't malign or question or otherwise the intent, the purposes, the idea of what Dr. Ballard was talking about, and I'm sure Trish Tilley would be talking about. What concerns me is that I am not 100% convinced that where there will be an adequate review in the as outlined in the original bill to protect the privacy of the people in the PDMP. It is clearly 100% in my book mission creep. That the only intent of the PDMPs, and I've dealt with them in several states because of my practice of medicine, is really to decrease doctor shopping and make sure that before I prescribe a controlled substance, I know what the patient's on, who's been prescribing it. That's the whole purpose. And I think when we talk about broadening that out, I do potentially see some benefit, but it seems a little bit more like a fishing expedition than it hasn't been explained to me exactly how this research would work. And some of the research already exists when you look at good controlled substances transition from amphetamines to opioids? Is there, and if it doesn't exist, doing a really good study is going to require institutional review board or an IRB. It's going to require, really well done study. So I don't really have a good sense of why DHHS wants access to this. I do think it represents mission creep. And so for now, until I have a better sense of exactly what they want to use it for, I would err on the side of protecting the privacy of the people in the PDMP and go with the amendment.
Anyone else?
I support the
Senator
amendment.
Whitley. Senator Gray.
Yeah. So, in weighing these interests, the privacy interests and the understandable desire to continue to look at what these drivers are for overdoses, I think, we do have a data set with this Medicaid population. And, I think there's a question, about what, because they pay for this, they do, as the payer, have access to a lot of information. And so it could be that this Medicaid data is used in a more robust way to achieve their goals. And also we know now that, there's other ways to identify what they're looking to do, like the YRBS data, the Youth Risk Behavior Survey that goes out, and that survey gets information to target public health dollars, to identify pockets of concern. So that achieves something that they had identified as an issue. So I agree that at this point, weighing those privacy concerns they in my mind, they outweigh the public health issues that we can get in other ways right now.
Senator Gray.
I'm going to make my remarks for SB 45, but they pretty much also apply to SB 29. That I don't believe that either of these bills, that the parties that have testified here today have had a chance to get together and give us a compromise bill that is something that addresses the issues in both the communities. Directly speaking to SB 45, we talked about random numbers and selecting databases and all of this. If in the PDMP, if I'm going to send a data set up to Health and Human Services, certainly I can assign a random number to each one of the patients in there, and so that the records by that random number would be associable. I could look at, prescriptions that they presented on date A, B, C, D, but it still would be unidentifiable back to the patient unless you were to go back to the PDMP. So I'm a little uncomfortable with what went on there, having dealt with large databases in the past. There are ways to make sure that is done. So I think that, again, speaking just for SB 45, the two parties need to be sent to the rooms by Senator Bradley, the chair, and tell them that they need to come up with the solution. And when both parties are equally dissatisfied, we probably have the right answer.
Senator Avard, thoughts?
I'm just going to support the amendment to 45. I think that's the direction to go. I believe that privacy matters, and that's important. I think the ability to aggregate this information and narrow it down to individual privacy violations. I just want a caution on the side of caution. I think that the amendment is where I'm gonna go.
Senator Sherman.
Yeah, just to follow up on what the other senators have said, I think the amendment, what's in the amendment needs to be done. Everybody has testified that needs to be done. The other is the part that needs to be worked out. So I think we can move forward with the amendment, and they can go ahead and continue the work on how to grant access to DHHS if they can do it in a way that we can all agree to, I agree with Senator Gray. Put them in their rooms and let them hash it out and figure out a compromise. But we still need to get that second part done, which is the amendment. So I'm in favor of the amendment.
So let me give a little historical perspective because it hasn't been mentioned, but I was the prime sponsor of Senate Bill 286 in, I think it was 2011 or 12 when PDMP passed, and Representative Kirk was rather a critic of it, and it was the type of privacy concerns that still exist. And had it not been for really strong privacy language in the original bill, it never would have passed the House in 2012. That is just a reality. Those concerns, I think, still exist. That being said, I don't have a problem agreeing with Senator Gray that the parties should try to work it out. My sense, though, is that people have spent quite a bit of time in trying to come up with the as introduced version of Senate Bill 45. And I think, you know, for our purposes, I'd be willing to give them, you know, some amount of time in the committee process because it doesn't have an FN to try to work it out. The governor will introduce his budget fairly shortly, and I do believe that part of the budget in HB2 will be to move the PDMP from OPLC to the Department of Health and Human Services. So Senator Sherman is right. Sections 3 and 4 of the bill need to move forward. But I think if the committee is all right with it, we can give them the department another week or so to try to work this out, maybe even 2 weeks. I don't know if John is, he's still on the attendee list. He hasn't disappeared. So I'm assuming, John, you've heard this.
Would you like
now you brought him to the top of the page. So he's raised his hand. Let's, you know, it's a normal process in an exec session to ask questions. So, John, I'm bringing you in.
Senator Bradley, thank you so much. And we agree with the committee members that the amendment that was brought forward is needed language. We actually worked as part of our bigger work product on that. We always appreciate additional time to try to work things through, but as you had identified, we have spent a considerable amount of time. When I say we, I mean collectively, Senator Gaida, other legislators, and the department and the Office of Professional Licensure and Certification. And I think at this juncture, and I'm just speaking right now very conceptually, would be thinking that moving the underlying amendment that was proffered today might make some sense. I probably, if I could just have a week to regroup with our folks internally to have that conversation, but I think we're leaning towards the wisdom that's been expressed by your committee members during this discussion on the bill.
All right, is everybody okay with deferring execing on the bill until next week?
And Senator Bradley, Senator Gaida has his hand raised again.
Sure. Go ahead, Bob.
Thank you, Mr. Chairman. As difficult as it is to say this, okay, I have worked, as you have worked, for years on this. I think that it's a tectonic change to move that whole operation over to HHS, which is already significantly, I won't say overtaxed, but I think they're doing the best they can with the COVID crisis and so forth. So I think moving it is fine. I'm happy to work with the department, and I'm sure that Senator Sherman, Senator Rosenwald, and anyone else that has a concern for the privacy of that information is willing to work. Again, as I said in my testimony, I'm not opposed to eventually providing access to data. But as Senator Sherman said, and as I believe Senator, was it maybe, well, one of the senators said that there are other ways to access that data that the department looks for without having to potentially jeopardize the privacy of the people whose data is contained in the PDMP. So, I'm certainly willing to work on it. I frankly, given the current conditions, I'm not sure that I could work on it this year. We definitely need to get the latter two sections of the bill done. And so, again, as we've done for the last 3 years now, we've met with stakeholders and moved forward. But the tectonic change of moving it to HHS, and in fact, where the current manager of the program was acting in violation of legislative intent, and in fact, attempting to sell the data at the very same time that the Attorney General was defending us against the DEA attempt to access that information. I mean, this brings a concern for trust. And I'm not willing at this point to cede that point to a department that has twice in the last 3 years, attempted to potentially breach that trust. That's difficult to state because the department has a huge role to play. At this point, moving it, I think, is enough. And I think that I'd be happy to come back and take a look at the language to provide access to that data under very restrictive conditions, as long as my colleagues would also support that. Thank you.
All right, Senator Gaida, I doubt very much that a compromise can be reached in the next couple of weeks. So our choice is, do we, as a courtesy, give the department a couple of weeks before we have to try to move the bill prior to the budget, when presumably the proposal will be made to move from OPLC to DHHS. I'm fine with that. This bill would not be on the floor until February 4th at the earliest. The budget obviously is going to take a long time. So I think we have a little bit of time. If everybody's all right, I think just the courtesy for John and Dr. Ballard is appropriate. Anybody have an issue with that? Okay, so we'll hold on that one for now. And then lastly, Senate Bill 29, I guess I would indicate the same thing, a courtesy this time to the sponsor, Senator Gaida. If I had to vote on this bill today, it'd be ITL and no question about it. But if there is a way to at least have the oversight board weigh in, I'm pretty sure I know what they're going to say, given the testimony, but I think as a courtesy to Senator Gaida, we can wait until February 3rd, which is 2 weeks from today, if everybody's okay with that. All right, I'm not seeing any objection, so we'll hold on that. I am not aware of any other bills that have yet been assigned to HHS, but hopefully there will be. And in tomorrow's calendar, we'll be meeting next week. Do you have any update on that, Griff?
Yeah, just give me 1 second. Some bills dropped in the past half hour, I want to say. So I want to load up what I had.
Funds are finance, energy, natural resources, and election law.
Yeah, so it doesn't look at this time there are 6 total bills in HHS. We just heard 3 of them. The next 3, one's about the collaborative care model service delivery method, advanced directives for healthcare decisions, and school district information on the COVID-19 dashboard.
All right, we'll be hearing all of them next week then, as long as they've been assigned to us, right?
Yep, it looks like they've been assigned to us, correct.
Okay. So presumably next Wednesday afternoon.
Sounds good.
All right. Is there
come out of exec?
To adjourn? Senator Sherman.
Do we need to come out of exec first?
Oh, yeah. I'm sorry. Thank you very much. A motion to come out of exec. Obviously, it has to be a roll call. Senator Sherman has moved, seconded by Senator Avard. We'll start with Senator Sherman this time.
Yes.
Senator Whitley,
Yes.
Senator Avard,
Senator Avard, yes.
Senator Gray,
Yes.
and I vote yes. And now Senator Sherman moves to adjourn, seconded by Senator Gray, Senator Avard,
Yes.
Senator Whitley,
Yes.
Senator Sherman,
Yes, yes.
Senator Gray,
Yes.
and I vote yes. Okay, thanks again to staff. Everybody got a chance to meet Kirsten, who will be our person on HHS. And I think thanks to Griff and Trish, it wasn't trial by fire for Kirsten today, but pretty soon.
Yes.
Okay, see you all next week.
Bye.
Thank you, everyone.
Take care.
Thank
Thanks.
you.